range of different cellular therapies. And when I say cellular therapy, it's what we've been doing in the past and what we're going to be doing in the future more and more. And in cellular therapy is transplantation of human cells to replace or repair damaged tissue or cells. And hematopoietic stem cell transplantation, which some goes by the name stem cell transplant or bone marrow transplant, historically and currently is the most common, most frequently used form of cell therapy. But as we are finding out and as we learn more and more about the potentials of modified cell therapy, such as immune effector cell therapy, CAR T cell therapy, NK cell therapy, tumor infiltrating lymphocyte cell therapies, immune effector cell therapies are present, and we're using them to treat patients with hematologic malignancies and melanoma. And what's really exciting is that, the technology has evolved quickly in the last 5 years to 10 years to really begin to use cellular therapy to replace defective cells with effective cells, and delivery of gene therapy in thalassemia and sickle cell disease are on the near horizon, as well as other inborn disorders that patients suffer from. So that is what cellular therapy is. And our team here at the Wilmot Cancer Institute has been doing cellular therapy since 1989. We have over 30 years of experience in doing it. And to be honest with you, I think we're closer to 4,000 cellular therapy infusions than 3,000 in both the adult and pediatric. We have an international reputation for superb clinical care, and clinical and scientific research are part of our comprehensive program. We're the first in Rochester, and in fact, the first outside of Memorial Sloan Kettering in the state of New York to do immune effector cell therapy for diffuse large B-cell lymphoma. And we continue to lead with mantle cell lymphoma, myeloma. We just did our first CAR T for myeloma this month, beginning part of this month. We have a dedicated ambulatory cellular therapy treatment area run by Meg and her team of nurses, including the infusion nurses, their nurse coordinators here, who you will hear a lot about. And we're beginning to do more and more of our pre-cellular therapy preparative regimens in the outpatient setting. We have a wonderful floor on the 6th floor of the Wilmot Cancer Center. Initially opened in 2013, but it's been expanded twice. And I think we were sitting at 27 or 28 beds with the 2017 and 2020 expansions. So it's all designed to provide state-of-the-art care to the patients in Rochester, Monroe County, and then the rest of the region of upstate New York. Next slide. So it takes a team, I think, as Karen was reading my introduction, I'm about team, and I played a lot of team sports growing up. I was more successful at team sports than individual sports. Maybe that's a reflection on my athletic talent, but in reality, team is what we do phenomenally well here at the University of Rochester. We have our cellular therapy physicians. We have over 75 years of combined experience. I am the third most experienced cellular therapist. Jane is Dr. Liesfeld, who many know, and Dr. Freeberg outranked me in terms of cellular therapy experience. We have a fantastic group of advanced practice APPs, advanced practice providers, and we've grown that group immensely by about threefold in the last 5 years. We have a fantastic group of nursing, the ambulatory coordinators who are the drivers of care, the inpatient nursing team led by Rona Henry on WCC 6, the apheresis team nurses in the collection area, and the ambulatory infusion area. We require the services of social worker, financial counselors, a dedicated cellular therapy pharmacist, and hopefully soon a second nutritional support a cellular therapy quality team, again led by Meg. As you can see, Meg has an ever-increasing role in our excellence, and a stem cell processing facility led by Dr. Liesfeld. We have a ton of collaborating physicians who are important to delivering this safely and effectively. In radiation oncology, we have a dedicated transplant infectious disease team here at the University of Rochester, as well as pulmonologists, ophthalmologists, and neurologists and cardiologists who have tons of experience in the cellular therapy care. And to build upon and improve the future of cellular therapy, we work with a growing clinical trials office so that we can offer state-of-the-art cellular therapy, such as our myeloma CAR-T trial that we've treated our first patient on, and all the KITE trials for the CAR-Ts for the lymphomas that we've run. So because the FDA considers each cellular therapy product a drug, and it's regulated by a number of external organizations which require us to maintain a high level of quality and standardization across the entire team. We are a designated NMDP center. That is, we do collections for the National Marrow Donor Program and both peripheral blood and bone marrow harvests. We have sustained accreditation since, I think, 1989, Meg, by FACT, which is the kind of like the JCO, if you're familiar with healthcare, or anytime you have an opportunity for the federal government to regulate you, FACT is part of that process. And we're part of the Radiation Injury Transplant Network, and we are Blue Quality Center for Transplant for the Blues, and the Center of Excellence for Aetna, Excellus, and Sigma. And all this goes to that there's an awful lot of external reporting that we do about the quality of how we do what we do, and making sure our outcomes and the way we do things are consistent with benchmarks established by national peers across the nation. So we do clinical trials as part of the Southwest Oncology Group, the Blood and Marrow Transplant Clinical Trials Network, New York State Tri-State Consortium, where we have a trial run. It's started by Dr. Sauter at the Memorial Sloan Kettering, and we're running it through the Tri-State Consortium, the NMDP, the CIBMTR, as well as industry investigator-initiated studies. Dr. Omar Al-Jatawi, who joined us about 5 years ago, has 3 clinical trials currently ongoing in how to improve outcomes for patients in the cellular therapy realm, looking at the role of hyperbaric oxygen. So how do our patients get here? I think it's quite varied. Most are referred from their primary oncologist because most of the malignancies we deal with are uncommon malignancies overall, less than 5% in terms of cancer subtypes. It requires a high degree of specialization. We have a strong, long-standing working relationship with most of the medical oncologists throughout the upstate region. Albany, Syracuse, Watertown, Utica, Elmira, Horseheads, Corning, Syracuse, going as far east as the Vermont border, Plattsburgh and Ogdensburg, and to Batavia in the west. There are some that are self-referred, some that come in and transfer from outside institutions for urgent care in the inpatient setting, a small number that are insurance dictated. This is the region that we cover. I have patients currently and in the past who've been from all over the map. Our current furthest away, I think, is several patients in Plattsburgh, and then a couple patients in the eastern side of Albany, all the way down to northern Pennsylvania, which is fairly common for us. So in terms of the types of cellular therapy that we do, the most common type currently is autologous stem cell transplant. I think most of the individuals on the call know that autologous stem cell transplant is used for multiple myeloma. It's our most common type of transplant, followed very close behind by non-Hodgkin's lymphoma and Hodgkin's disease. Rarely germs, with the success of chemotherapy for treating germ cell tumors, we've become less involved, but we still remain a treatment option for patients with relapsed germ cell tumors. In the realm of the future for autologous stem cell transplant, we recently were asked to participate in the NIH, the National Institutes of Health, sponsored clinical trial, the application of autologous stem cell transplant in the treatment of a defined patient population and multiple sclerosis. But autologous stem cell transplant just refers to self into self. Allogeneic stem cell transplant has grown quite a bit in the recent past. It involves using hematopoietic stem cells from a donor who is not the patient. It requires HLA typing with the intent to find out what's the best possible donor. Is it a sibling donor where it's a 6 out of 6 match, which means you're a 10 out of 10 match, except in rare cases. And each sibling has a 25% chance of being a match. An allogeneic donor who's not a sibling, an unrelated donor, there we have to do a full 10 out of 10 match because each of those barcodes on each of those stripes on our barcode can be, aren't exactly always arranged together. But the exciting part in allogeneic stem cell transplant in the past 5 years is increasing use of what we call haploidentical donors. That is, patients who are only a 5 out of 10 or a 3 out of 6 match with a sibling or a parent or a child. And this pretty much opens up allogeneic stem cell transplant to over 90% of patients who come to us if it's appropriate to use a haploidentical transplant, because this is an evolving technology, and for AML and for ALL, there are fairly large trials that have demonstrated the efficacy of this approach. Less common diseases that we may not have a solid data in the haploidentical transplant setting. And so haploidentical transplant is a completely novel way. We participated in a clinical trial at the national level, comparing it to cord blood transplant. That trial was closed about 5 years ago, and we're just getting the results out for that. That was in the setting of acute myelogenous leukemia. And we're also interested in cord blood stem cell transplant. I know there were questions regarding cord blood stem cell transplant in the questions submitted. Dr. Al-Jatawi was recruited from University of Kansas, I think almost 4 years ago. And he is our expert in cord blood transplant and is running that program. So now allogeneic stem cell transplant, auto transplant. The area of greatest growth and potential growth in the future is chimeric antigen receptor T cell therapy. So part of what we think about when we think about allogeneic stem cell transplant is how do you use the donor's immune system to treat the leukemia when chemotherapy, or the lymphoma, or the myeloma when chemotherapy is no longer effective. Chimeric antigen receptor T cell therapy is taking the patient's T cells and redirecting them back to the tumor and trying to use the patient's own T cells to attack the tumor. And to do this, you collect the T cells just like we would for a peripheral blood collection. They're modified to express a specific receptor called a chimeric antigen receptor, CAR, hence the term CAR-T. And this special receptor has been designed to target a certain protein on the surface of the cancer cell and then activate the T cells to kill the tumor. And we're learning more and more about it. It's been approved by the FDA for the treatment of diffuse large B-cell lymphoma, mantle cell lymphoma. We've been doing, on average, 25 to 40 CARs a year for these indications. We just opened up and enrolled our first patient on the myeloma CAR-T trial. It's been approved for pediatric B-cell ALL, and we have a current trial for adult B-cell ALL. And we also have a trial for follicular non-Hodgkin's lymphoma. Next slide. So we report all of our data to the CIBMTR, and this just gives you an idea of what kind of transplants are used for what. Myeloma and plasma cell dyscrasias, overwhelmingly auto. Same thing for non-Hodgkin's lymphoma, Hodgkin's disease, and germ cell tumors. And the rest of the diseases, AML, myelofibrosis, MDS, ALL, and rarely CML and aplastic anemia. Those are where we use allogeneic stem cell transplant. And across the nation, these are the US data in terms of what type of transplants are being used. We're seeing increasing numbers of unrelated transplants as we begin to do more and more transplants in patients beyond the ages 60, 65. And then we're seeing an increase in the use of haploidentical, that's the green line. And at the same time, you're seeing kind of like a drop off in cords and a drop off in match-related donors as we use more and more unrelated donors of a youthful age, we'll just say that. Go ahead, next slide. And this is the relative comparison of the number of auto transplants for allo. And our centers are pretty similar to that. We're usually 60 to 40 or 70 to 30, depending on the year-to-year variation in terms of autos to allos. These are the actual numbers in terms of the number of transplants. So we've grown the program quite a bit in the last 10 years. We used to do about 110 to 115 transplants a year, but in the past 3 years, we've averaged somewhere around 180, 185. Next slide. So determining who gets what kind of transplant is an important decision, and I think it's almost entirely disease driven. As I showed you on that CIBMTR data where you looked at the disease and whether auto was predominant or allo was predominant, you saw that for myeloma. You didn't see any or very few. It's very rare that we would do an allo transplant for multiple myeloma. And with CAR T therapy becoming available, I think it'll become increasingly rare. Lymphoma, there are some patients with lymphoma that we pursue allogeneic stem cell transplant, and usually in the setting of having recurred after an auto transplant. In terms of AML, there are some centers that do autos for AML, but it really is an allo-based disease in 2021. So we aligned the type of transplant, the stem cell type with auto or allo. Then we think about what chemotherapy we use before the stem cell transplant. And autologous stem cell transplant, it really is about being able to give high doses of chemotherapy that we could not use without stem cell support. Whereas with allogeneic stem cell transplant, it really is what's the disease, what's its responsiveness to chemotherapy, and what's the age of the patient and their comorbidities. And auto, it's about self. And allo, we have a rank order, preferred list. You know, if we have a patient who has a sibling who's less than 50, that will be our go-to. If we have a patient who has a sibling of 70, but we have an unrelated donor who's a 10 out of 10 match and who's 23, many physicians would be inclined to go with the unrelated donor in 2021. If we do not have a matched sibling donor, if we do not have a matched unrelated donor, then a haploidentical transplant with a 5 out of 10 child or sibling would be a reasonable thing. So it's on the auto, it's fairly linear in terms of, auto, a myeloablative conditioning, which is high dose chemotherapy, which ablates the bone marrow, 100% match, and almost always PBSCs. On the allo side, it really is more, it's data driven, and there's an art to it where the experience of the center and the transplanters comes into being. And that's why, there are some centers such as Albany and Syracuse that do autos at a small number. But for allogeneic stem cell transplant, you're either on you're on the island, Manhattan, you're at University of Rochester, or you're at Roswell Park for an allogeneic stem cell transplant in the state of New York for the big centers. Next slide. Who's a candidate for cellular therapy? Well, That is where we see our patients on the first floor of the Wilmot Cancer Center, and the initial assessment is where we learn about the patient. There's interaction. The patient gets to learn about myself or my teammates. They get to meet the coordinator. It's really about disease and what prior therapy the patients had, what has been their response, what is their other medical history, their comorbidities as we call them, hypertension, diabetes, heart disease, history of solid tumor. What is their social support? It's very important to find out who's going to help them get through the stem cell transplant. What's the family history? Is there a strong family history for cancer? And in 2020, 2021, telemedicine has allowed us to really to enhance patient care by doing some of this with patients who are in Syracuse and Utica, Elmira, that first visit as we try to enhance patient care. And the recommendation of what type of transplant is a complex process based on disease, prior therapy, and the expertise of the physicians and the tumor boards that we have here at the University of Rochester. Trust me to say that part of the decision to being a candidate for a stem cell transplant, it's not just the physician's opinion, it's also a lot of pre-transplant testing, staging, response to therapy, radiographic response, bone marrow biopsies, tissue typing, dental clearance, PFTs. If Steven's been through this, he knows that the coordinators line them, we try to do as much as possible close to home, but overall, I think it's quantitative assessment of where are the risks to the patient. Next slide. In terms of, I think we'll skip this because I want Meg to be able to talk proudly about her team, but bone marrow, mobilized peripheral blood, and CAR T, these are the different sources of our cells. And if you have questions at the end, I can take that directly. Next. So education, and I'm going to let Meg take over. I think one of the most important processes that we're continually trying to improve and work upon is how do we educate our patients without turning them away from a potentially life-saving therapy. Because I could go into great detail about what's involved in an autologous stem cell transplant for multiple myeloma, and the patient would walk out of their office and never come back because of it's kind of like the last 5 seconds of a drug commercial, everything that could possibly go wrong. So I rely heavily on my nurse coordinators and my nursing team, which Meg leads excellently, to help provide that understanding to help move forward. I'll leave it at that. Meg?
So for anyone who's ever been in a physician's office or at a doctor's appointment, you know how important it is to work with your nurses. They are kind of the lifeline through the process and help to provide education related to the therapy. And I'd like to highlight some of my team members since they are so incredibly wonderful. So we have 2 separate teams in the coordinator office, the auto and immune effector cell therapy coordinators, Cherie Guarino, Jillian East, and Alyssa Nowakowski. Alyssa is new and came to us from the inpatient unit. We have 2 nurses who job share in allogeneic and pediatric coordinators, Ann McKenna and Sharon Swift. And then I have 3 allogeneic coordinators who work on the adult side alongside Sharon and Ann, Allison Vogel, Beth Wenzel, and Connie McMullen. So education really in the setting of transplant is key, and this is what the coordinators do incredibly well. The coordinators are responsible for educating patients about pre-admission issues such as the cell therapy collection, the need for catheter, the working with insurance companies, working with outside groups such as the home care nursing, working with patients to help them understand what the effects of the therapy are going to be, and coordinating with outside offices. They schedule chemotherapy, they make sure that everything is going smoothly, and then they communicate that with the patient. Then when the patients get ready to go into the inpatient unit, they help them to understand what they need to bring with them, talking to them about visitors, using helmets to help to decrease the chance that they may, during periods of low platelet counts, have a head injury if they're walking and they fall, and making sure that patients understand the rules of the transplant unit, including trying to stay on the unit once they're admitted, to increase the potential for success for the transplant. In addition to all of those things, the nurse coordinators are the ones that help the patient to understand all of the potential consequences of getting chemotherapy, including any kind of transfusion needs, any side effects that they might experience, potential for organ damage, infertility, fatigue. These are some things that can affect the quality of life of patients. So it's very important for people to understand this up front, and is a big part of what our discussions entail. We also need to ensure that they're aware of the fact that they're going to be getting some low counts. They're going to have fevers. They will likely get antibiotics during the inpatient stay, and that there will be other medications that could be used in the short term in the hospital that may continue during the long term after the hospitalization continues, such as immunosuppressive therapy. It's also very important to have a caregiver present after transplant. And for anyone who has ever had any kind of surgery or any kind of medical procedure, you probably know how important that person who's sitting next to you can be to ensuring that you have a successful recovery. The caregiver is incredibly important. So it's important for the caregiver to be a part of the conversation of transplant from the beginning, and that they have as much support from the medical team as the patient does. The expected time for recovery for patients can be lengthy, depending on what type of transplant you have. Patients who receive auto transplant tend to recover fairly quickly, whereas patients who have allo transplants tend to take a little bit longer. So it's important for patients to hear these things so they set realistic expectations for themselves. We have local rooming options here at around the Rochester area, and we work with these rooming options to ensure that patients who don't live in the area or their caregivers or families that need to stay locally are able to do so at a lower cost. And we do anticipate generally that most patients will have some needs after discharge, even if it's just working with their local offices to get them in weekly for labs. For some patients, it's a lot more than that, but the nurse coordinators help to coordinate all of those different pieces of needs. As far as post-transplant follow-up, it could be as little as you're following up just once a week for a few months and then returning to your local office, or it could be as often as needing to come in daily or maybe even a couple of times a week. And the reason I mentioned daily is because some of the patients who do receive CAR T cell therapy could potentially need to come in daily, depending on how they're doing when they're discharged. We try to reduce the amount of time patients have in the hospital as much as we can by using our outpatient facilities, because we understand how important it is for patients to spend time at home and to not be in the hospital where they're being woken up pretty frequently. So, being able to use the outpatient infusion services and the outpatient clinics pretty regularly have helped us to accomplish that. We also have restaging post-transplant and also some follow-up visits, and the coordinators help to educate patients as to what their specific plan is going to be. The most important thing, though, that I hope that they're conveying to patients is that there are going to be some limitations, and it's really important to be realistic about how you're feeling after transplant. And it's also really important to take care of yourself. And that includes, walking regularly, moving around, having some interaction with family to keep up your spirits, and making sure that you're eating a well-balanced diet. For patients who are getting auto transplants, those patients with multiple myeloma and lymphoma generally, the care is pretty standardized. For multiple myeloma patients, once you're discharged, if you're doing well, you are seen in clinic within a few days after you're discharged. And then again, about a week later, then at day 30 and day 60. And after day 60, you're sent back to your referring oncologist, who will see you and continue to monitor you. For those patients, they can start getting revaccination of their baby shots at about 6 months post-transplant, and that can help to bolster their immunity against those kinds of diseases. Lymphoma patients are seen about on the same schedule. However, they do go back to their referring oncologist, usually to get their restaging, and that happens at about day 100. For allogeneic post-transplant patients, just so that you're aware, the follow-up is a little bit more lengthy. We do see those patients pretty regularly, usually twice a week after transplant for the first week or two, depending on how they're doing, and then weekly thereafter for a few months. If they're doing very well, we then start to see them every other week and then monthly. So that's a little bit different. So I'm sure that we answered maybe some questions, but I do know that there are some questions that we didn't answer. And I do have a list from Karen. If you don't mind, I would love to read those out, and then either Dr. Becker or I can answer those. So the first question that Karen had sent out was, what is the range in age for stem cell transplants? And has this range changed in the past 5 years?
So I would say, yeah, the range is, I'll say, ever increasing. There's 3 different reasons for that. The first is most oncologists and most oncologists at academic medical centers where stem cell or cellular therapy units are really try to make medical decisions based on what published data reports to be effective. And there was a significant bias in stem cell transplant, and specifically in inclusion of older patients on clinical trials. So we had there were concerns about the safety and efficacy of doing transplants in patients older than 65, where most trials cut off enrollment at. But for myeloma, which has led the way in this, we've really, that over the last 5 to 7 years, that barrier has come down further and further. Just as a case, I had an 82-year-old that was referred for upfront transplant for multiple myeloma. And in his specific case, I didn't think he needed an upfront transplant, but I will say age is no longer a major determinant. It's more about overall health, comorbid illnesses, benefits of the transplant, and we do have a dedicated geriatric hematologist who will see patients over the age of 70 or 75 as part of our pre-transplant evaluation to help us in making decisions in identifying patients who may be under 75 but or under 80 but who have geriatric syndrome that would make transplant more risky. Second, the federal government, and let's say for instance, myelodysplastic syndrome, there is recent data that was part of a large clinical trial that we participated in, data reporting study, where they demonstrated that the benefits in terms of responses and overall survival in patients over the age 65 is equivalent to patients under the age of 65 for myelodysplastic syndrome. So there we're beginning to get better support to do the clinical trials in the older patient population to demonstrate that these are efficacious and safe.
So the next question is, when doing an auto, and I think this is a typo for an allogeneic stem cell transplant, are they still searching for at least a 9 out of 10 match? Is 8 out of 10 still not acceptable?
So let me just go back and reiterate on this slide. Our donor choices are for allogeneic stem cell transplant have changed in the last 5 to 7 years. And so, and this is where it gets into the specifics of the case. So if you had to ask, what are our preferences? A young 10 out of 10 allogeneic stem cell sibling donor would be our first choice. I think there's very little question about that. When we get into 10 out of 10 matched unrelated or 9 out of 10 matched unrelated or haploidentical, then it's getting into what is the age of the donor, what are the ABO, CMV, other phenotypes, and what is the disease. Say, for instance, for AML in first remission, I might actually choose a haploidentical child as a donor as opposed to a 9 out of 10 matched unrelated donor. A 10 out of 10 matched related donor versus a haploidentical donor, age might be a driver of it. Yes, we can use 9 out of 10 donors in unrelated donor stem cell transplant. I don't think I've done an 8 out of 10 donor in the past 10 years because we have better options in terms of haplo. And we do have to modify if we're going to use a 9 out of 10 or an 8 out of 10, the immune suppression to account for that. But it's where the expertise of the physician, understanding of the disease and what you're trying to accomplish with the transplant.
So another question is, what is your success rate for individuals greater than 60 years of age with no comorbidity with allo-BMTs?
So this is where all that alphabetical soup of organizations that we report our data, CIBMTR in fact being the two predominant ones, matters. So as part of maintaining our FACT accreditation and maintaining our member in good standing with these groups, we have to report our outcomes for all transplant types. And so there are national benchmarks, and those national benchmarks are established by these organizations, and we achieve those benchmarks. It's going to be if you look at individual centers and morbidity and mortality, we tend to take higher risk patients to transplant. So you have large centers that do a lot of transplants, and they set a gold hard fast rule that your outcomes have to be overall survival at 5 years at 30% or more. So if you have a disease where that's not the case, where you have patients who may have a 15 or 20% survival rate at 5 years because of the nature of the disease, they would not transplant you, and so their numbers will look quite good. Now, the FACT and CIBMTR look at that in their benchmarking and their data reporting. And so a center that does who sets a lower bar, such as we do, in terms of overall survival benefit for a transplant. Because if you have someone, most of the time in the allogeneic setting, we're looking at patients who have chemotherapy, overall survival benefit of 5 to 10% versus allogeneic stem cell transplant of 20 to 30%. And you might not be eligible at Memorial Sloan Kettering for a transplant based on their cutoff. And that's just the truth of the matter. And so by using what individual physicians make that decision here, and the FACT and CIBMTR data suggests that even though we're taking on a higher risk of patient, we're performing admirably and we're exceeding all of our benchmarks. That's probably the best answer I can give. Is that, I'm hoping that my gobbledygook speech didn't, just it made it understandable. If someone wants to follow up with
I think you're good, Becker.
Okay.
So I am to have.
Notice she said, "I think you're good, Becker."
Yeah.
This is our team approach. I want to say a big shout out to Ms. Callahan, who I just noticed on the Catherine is a longtime friend.
So the next question that I was given by Karen is, I am to have a double umbilical cord blood stem cell transplant this summer. How many have your center done for post-PV, MF, MDS, and what is the successful engraftment rate? What is the survival rate at 100 days, 6 months, 1 year, 3 year, and 5 years?
So I think we do the most cord blood stem cell transplant in New York outside of Memorial Sloan Kettering, where they have an expert in a dedicated cord blood program. And we do, Meg, do you have that data, that slide? If you could put that back in terms of our cords. Dr. Aljotawi was brought here to run our alternate donor program, and he has revamped the cord blood program. So he's been here, I think I keep thinking either 3 or 5. I keep getting older each time I answer that question. So we are doing an increasing number of cord blood transplants. And you can see in 2017, before he arrived, we did 2. In 2018 and 19, we did a total of 11, and we've done 12 in 2020 because he's ramping up the use of cord bloods on clinical trial. So I do think that, it's a growing program for cord bloods. Many centers are, as you go back, if you show the CWMTR data, you'll see that most centers are moving away from cord bloods. That's that, what is that? That's that light blue line. So that since the onset of using haploidentical cord bloods are becoming less often, less frequent. So our data on the cord bloods is relatively new. And in terms of myeloproliferative disorders such as myelofibrosis are probably about 1/5 of our total allogeneic stem cell transplant, maybe 1/4 to 25%. So you can just to say that, what is our failure rate for engraftment in the adult cord blood setting? I think our failure rate for engraftment is probably sitting around 10%, which is the national, where we would expect it to be based on several large national trials in allogeneic stem cell transplant, 10 to 12%. I think that in myeloproliferative disorders, breaking it out between AML, MDS, and myeloproliferative disorders, I think we have maybe an 1 or 2 over that time, and I just don't know the data for that one.
And then the survival rate?
So the survival rate is actually better than the published literature for our cords in terms of overall survival. Understand that cord blood transplant in the adult setting is a treatment that you need the dedicated expertise of the individuals like Dr. Aljotawi who have dedicated their lives to cord blood transplant. So I do think we're always, with all diseases, all transplant types, we're monitoring our overall survival rate, and our survival data is better than the most recently published trial in myeloid malignancies.
And then the last question that I was given is, I had a CAR T in December. I'm currently in salvage BRPOLA therapy for DLBCL. I may be considering stem cell transplant later this year. Are there any specific concerns for someone post-CAR T?
So great question. They're all great questions. And let me just turn the lights back on. So I think that this is this is a big question that we have to ask in patients as we move CAR T therapy further up front in diffuse large B-cell lymphoma, follicular lymphoma, mantle cell lymphoma, where we will still likely need in uncommon circumstances to consider an allo after a CAR T. And I think that the data from the KITE studies that we've been part of, and the data from the pediatric ALL studies that Novartis product utilizes, Carl June and his group at University of Pennsylvania, suggests that that prior CAR T doesn't really have a significant impact on outcomes after allogeneic stem cell transplant, except for as it goes to, it's an additional line of therapy that the patients had before they got to allogeneic stem cell transplant, where each prior line does increase the incidence of or likelihood of recurrence. But I do think that in terms of CAR T specific problems, we have not in the cases we've done so far.
All right, so I'm going to stop sharing, and I would love to have any questions that you might have. Please feel free to ask.
There are a couple of, can you guys hear me okay? Okay. There are a couple of comments actually in the chat box extending their profound thanks to Meg, Dr. Becker, and the incredible team for their care provided at Wilmot Cancer Center. So a great thank you for one of the participants on the call. And I believe you just answered Jeremy's question as well. So I'm not sure if anybody else has any other questions.
I have a question.
Sure.
If you have stem cells, if you're going in for your second transplant and you have stem cells frozen, do you get the same, do you go in for the same amount of time? Are you there for like the same amount of time as you were for the first stem cell transplant?
Great question. So the straightforward answer is yes. The stem cells, by being in liquid nitrogen for years, they don't appear to lose any potency for the first 10 years. I think the furthest I've gone with is probably 15, maybe 16 years between transplant 1 and transplant 2, and the patient engrafted just fine. I think the second transplant is actually easier in most patients. Now saying that, let me make knock on wood, because the first transplant is really, you know, your first flight. It's your first time doing this novel, where Becker has talked to you for an hour about diarrhea and fevers and nausea, and he almost talked you out of it. And second, you know, he's wrong on the diarrhea because it didn't go nearly as bad and so it really is been there, done that kind of. Your knowledge base is so much better, and that gets to why it's important for Meg's team just to be they're so critical in that education piece beforehand, so that it's as close to having been there, done that for the first transplant. Does that make sense?
Yes, it does.
But the stem cells work. The stem cells, do you have a little bit more diarrhea? Sometimes yes, sometimes no. Do you have a little bit more oral discomfort? Sometimes yes, sometimes no. Do you come better prepared for hospital food, hospital coffee? Yes, almost always. And the beds are no better in 2020 than they were in 2010.
Okay. Thank you.
Same great nursing though.
Okay, thank you. Okay.
Other questions?
There is one other question in the chat box. How often are children used for stem cells if siblings don't match?
Good question. Great question. So it's increasing. I think, 5 years ago, I never did, right? Now I have 5 or 6 patients that their child was the donor. Our first, my first, haplo, the daughter who's like 5'6" and wafer thin, and the father is bigger than I am, was my first haplo, and it worked beautifully. So it's increasing. I think there are issues related to mother-daughter, or mother-son, father-daughter. So they're specific expertise. We learned a lot on our clinical trial on how to do haplo well. So that knowledge of participating in the clinical trial has led to improved outcomes and care for the patients that followed. There's a shout out to the peer counseling programs from the BMT InfoNet and Leukemia and Lymphoma Society. I do think that the peer, the BMT InfoNet, the Leukemia and Lymphoma Society are fantastic organizations. We participate as a team, or we did before COVID, in Light the Night and the LLS, and looking forward to doing that in the future.
And I would agree. I think that it's important, especially if you have a lot of questions about what transplant is going to entail, to hear about someone else's experience. Not that everyone's experience is going to be the same, but you go in with a little bit more information, and information is really key when going through transplant.
Any other questions?
Dr. Becker,
Yes.
speaking of COVID, I've had my COVID vaccine. After the transplant, you most likely will have to get them again, right?
Yeah, so that's brings up vaccinations. We usually revaccinate everybody 6 months after transplant. Yes, I think I anticipate, I don't know any more than you do on whether COVID will become annually like the flu, or twice a year like a new vaccine. But yes, patients should get revaccinated. And our standard right now for COVID is 4 months, at least 4 months after the transplant, before your immune system will have a sufficient response to warrant vaccination.
Okay, thank you.
Anytime. All right. Well, it's been fun. If you have any questions, just reach out. We have a website that's being developed better and better. That's probably poor English. Our website is being enhanced. So, and if you have any questions, just reach out to the Wilmot. And finally, Jim asked the question, is stem cell transplant considered more of a last resort if approved therapies are not available? And the answer to that is no. So it depends again on the disease. So multiple myeloma, despite all the advances in myeloma, most experts in myeloma consider stem cell transplant to be part of the upfront approach, the initial treatment, induction, transplant, maintenance therapy for the best and longest response. For acute myelogenous leukemia, it actually is, there are some studies that suggest that transplant in your first remission is associated with better outcomes than transplant in your second or third remission. For large cell lymphoma, transplant in your first relapse is better than transplant in your second relapse. For follicular lymphoma, transplant in your first recurrence is better than transplant in your third or fourth recurrence. So it all depends on the disease. But there, unfortunately, our science and state of the art for many of the diseases that we've mentioned diminishes quickly after the first response. And so it goes to the needs for, it just goes to the needs for better therapy so that I don't need to do transplant. But we're not there yet for most of these diseases. So, say for instance, myelofibrosis or myeloproliferative disorder, this is a question that didn't even get into the, if you're older and you have low risk myelofibrosis, low risk prognosis, myeloproliferative disorders, transplant's worse if you do it up front than if you wait until the the risk goes up. Whereas if you're young, less than 65, and you have lower risk myeloproliferative disorder, transplant's actually better if you do it earlier than if you wait. So it's really a very, the question goes to, we're getting more and more information about when is the appropriate and best time to apply transplant. And almost always, if you wait beyond where the data tells you to do it, it's very difficult for transplant to work. I hope that helped. So follicular lymphoma. So Carla Casula here at the University of Rochester demonstrated retrospectively that the duration of the response to your initial therapy to follicular lymphoma predicted whether you should go to whether you do more chemotherapy if you do transplant. So I don't think it's called the Casula score, but it is it's a prognostic score that, depending on your duration of response, auto transplant in second remission is the preferred treatment choice for the patients who have a certain duration of response up front. Whereas if you have a very prolonged duration of response to your first in follicular lymphoma, then auto can be delayed to your second CR or second recurrence. I hope that helped. All righty.
Well, thank you both so much. Thank you, Dr. Becker. Thank you, Meg. Thank you, everybody else, for joining us. We definitely appreciate you taking time out of your schedules. And we did record this, so if anybody wants to go back, I will be posting this to our YouTube channel by tomorrow.
Thank you. And Karen, for anyone who has questions about CAR T therapy, if